Okay, fine. So we can start the session. And the very first question was about the sexually transmitted diseases. And here the question was like, a patient had multiple painful ulcers over genitalia after sexual exposure. Now, what can be the diagnosis? Yes, anyone? So, multiple, and second is painful ulcers. So, the moment you have these kind of keywords in your question history, the answer should be chancroid. Okay, so the answer should be chancroid, which is also known as soft chancre. Now, this has to be differentiated from syphilis, which is also known as hard chancre, and here the lesion is single, right, and it is painless ulcer, right? So, and third is, of course, if you look at the induration, so here induration is absent and here induration is present, right? So just three important differences between syphilis and chancroid. So syphilis, which is hard chancre, and chancroid, which is soft chancre, right? So if you have a case history where the patient has multiple painful ulcers, straight away go for the diagnosis of chancroid, right? Remember, in syphilis, the lesion of primary syphilis, in fact, that is painless and single with induration, and therefore it is known as hard chancre, right? So that is one thing. Now, sometimes there is one more condition, and that is known as herpes genitalis, right? So here what happens, there are multiple grouped vesicles. Clear? So there are grouped vesicles which might later ulcerate, and therefore this condition is discussed in genital ulcer disease heading. Shahnawaz bhai, chancroid is painful, syphilis is painless, right? So that is very important. Okay, so please remember, syphilis painless, chancroid painful. Okay, so no problem. So herpes genitalis is again, the patient is having multiple grouped vesicles which ulcerate, and this causes painful ulcer, right? So the keyword for herpes genitalis is that there will be multiple ulcers, there will be multiple vesicles, right, in a group. So this is how they will be seen, and yes, they will be resting on an erythematous base, right? So there will be an erythematous base, if you can see something like this. So there will be redness, and over that redness you will find small vesicles which are in a group. So this is known as grouped vesicles. So therefore this word grouped is very much suggestive of herpes genitalis, right? So these are three important conditions which has to be discussed if you have a case history something like this. So multiple painful genital ulcers, go for straightforward diagnosis of chancroid, which is caused by Haemophilus ducreyi. Okay, so these are the three conditions which you need to discuss here. And then we have other conditions also, like lymphogranuloma venerum or donovenosis, but that is not of much, there is no point in discussing those conditions in this particular case history. Okay, chalo. Next question is about a lady who is having sun exposure and now is having brownish pigmentation as is shown over the face. Now what is this? Okay, Shanawaz bhai, perfect. Painless for syphilis, yes, agree to that, no problem. Okay, so this particular question, there is a lady who is developing brownish pigmentations over the cheek after sun exposure. Now, what condition is this? For some straightforward questions, I have removed the options, and I just want to, develop this habit of spot diagnosis. The moment you see the image, the diagnosis should click in your mind. So this is, yes, anyone who would like to answer this for this particular question? Anyone? So this is actually melasma. Okay, so this is melasma. Fine. Chalo. Anyway, let's move on to another condition, another question. And here there is a child who was having history of sore throat, and then was started on antibiotic, and now he developed the lesions as shown in the image. So any idea what lesions are this? So one is past history of sore throat. If I just zoom up the lesions little bit. Now this, I think, will be a little difficult for students to answer without options actually. So this is actually a type of, this is a variant of psoriasis. Okay, so this is a variant of psoriasis, and this is seen particularly in children's, right? So it is seen in children's, and there is a past history of sore throat, and we all know that sore throat is streptococcal. Suresh Chandra Chauhan, I haven't prepared any timetable yet, but yes, if you say, I'll prepare a timetable, and I'll try to take maximum subjects before August 10, and for these all sessions are for NEET-PG, right? So yes, tonight I'll make a schedule and I'll upload it in the Telegram group. Okay, so no problem. I'll make a schedule, and yes, you should have a prior knowledge, like what subjects will be discussed on what days, right? So that I'll do. That's a good idea. Yeah, agree to that. Okay, so this is a variant of psoriasis, where this variant is especially seen in children's, and there is a past history of streptococcal infection. Now, the moment you have these kind of words, you have to answer. This is Gatate psoriasis, right? So this is Gatate psoriasis, and here you can see raindrop type of lesions. So these are known as raindrop skin lesions. Clear? So this is very important for diagnosis. Children, past history of streptococcal infection. So this is Gatate psoriasis, which is one variant of psoriasis. And yes, of course, when we discuss psoriasis otherwise, so if we discuss psoriasis in general, this is, what important points you should remember. Silvery scales in number 1, right? Then number 2, extensor distribution. Right, so back of the forearm, front of the thigh, or front of the leg. So extensor distribution, or back of the chest, back of the neck. So that is all extensor distribution. Then third, which you should remember for psoriasis, is of course there is Auspitz sign. If you remove the scales, there are pinpoint bleeding spots. That is Auspitz sign. So this is specific. There is one non-specific term, and that is Koebner's phenomena, right? So that is Koebner's phenomena, and I think most of you must be knowing what is Koebner's phenomena actually. If suppose if a patient is of psoriasis and if there is trauma to normal skin, sometimes later there will be development of psoriatic lesions. Clear? So this is the Koebner's phenomena for psoriasis, but it is, as I told you before, it is non-specific, means it is not only limited to psoriasis, it can be seen in vitiligo or lichen planus as well. So it can be seen in vitiligo or lichen planus, right? So these are few important points which you should know about. Yes, it is in psoriasis. Very good. PLV, understood. Psoriasis, lichen planus, vitiligo. Yes, Shanavas, you are absolutely right. So this is Koebner's phenomena. Okay. And then there are many more questions on psoriasis later on, so we will discuss them later, right? Now, there is one condition which is shown in the image, and it is asked like supplementation. What supplementation can treat this condition? So if you look here, right, you can see. Any idea what is this? Yes, any idea what is this here? You can see hyperpigmentation in the front of the neck and upper part of the chest. What is this? Any idea? And if you can identify the condition, you can answer like what will be needed for treatment. Yes, anyone? What is shown in this figure? Yes, anyone? See, this is the typical Cazals necklace. Okay, so this is Cazals necklace. And whenever yes, Arush, perfect gentlemen. So this is a case of Pellagra, right? So this is Cazals necklace. So this is a case of Pellagra. And whenever you say Pellagra, treatment wise, you need to supplement niacin. Very good. So niacin or nicotinamide, whatever is given in the options, right? So this is the answer to this particular case. Now this is the typical Cazals necklace of Pellagra. Chalo, the next question, and it's slightly difficult question, so I have given the options for this. Now, what is this Malpighian layer when we discuss the anatomy of the epidermis? Yes, Mohammad Shanawaz, vitamin B3, very good. Niacin. What is this Malpighian layer in terms of anatomy of epidermis? Any idea? See, we have 5 layers if we discuss the skin in palm and sole, and the remaining portions we have only 4 layers, right? So if we start from outside, the outward is stratum corneum, right? Then the layer which is not always present is stratum lucidum. Okay, now this lucidum is present only in soles and palms, right? Over the remaining part of the body, over the remaining part of the skin of the body, it is not seen. It is only present in soles and palm, right? Then after that, the further deeper layer is stratum spinosum, granulosus, right? Then even deeper is stratum spinosum, and the deepermost is stratum basal, right? So these are the 5 layers going from outward to inward, right? So if we are going from out to in or the deep side. So yes, Shahnawaz, you are absolutely right. Now these two layers collectively are known as the Malpighian layer, right? So spinosum and basal, these two layers are collectively known as the Malpighian layer, right? So this is actually the terminology of Malpighian layer. Now, why this spinosum word is here? Because there are some impression of spines, and these are because of desmosomes, right? So these desmosomes, it gives a spinous appearance, and therefore this layer is known as stratum spinosum. In the layer superficial to it, that is granulosus, there are keratohyaline granules, right? And just because of these granules, it is known as granulosus. Okay, and as I told you, lucidum is not present everywhere, so it is present only over palms and soles. So these are the 5 layers, and of course the layer number 4 and layer number 5 together constitutes the Malpighian layer, right? So yes, this is basal, and this is spinosum, this is granulosum, then lucidium, and then finally the corneum. Okay, so these are the 5 layers, and spinosum, and that is because the cells, they are connected by desmosomes. So if I try to show you in the image, you can see these are the keratinocytes. Okay, right, these are the keratinocytes, and these keratinocytes are joined by desmosomes, right? So these are the desmosomes, and these desmosomes gives a spine-like appearance, and therefore this particular layer is known as stratum spinosum. Okay, so this is all stratum spinosum. Fine, something like this. And in the granulosus layer, there are keratohyaline granules, and therefore we use the word stratum granulosus, right? So these are the 5 layers, and the last 2 or the deeper 2 are known as the Malpighian layer. Chalo, next question. A 7-year-old child, right? A 7-year-old child, there is a history of asthma, and now he is having itching and rashes in the axilla, groin, popliteal region. What can be the diagnosis? So the key point to note here is that child, right? History of asthma, and then itching over axilla, groin, popliteal fossa. So the moment you have these 3 important keywords, and again the highly important keyword is history of asthma followed by itching. These 2 points, the moment you get these 2 points in the case history, you have to answer it as a case of atopic dermatitis, right? So this is a classical case of atopic dermatitis, and sometimes it is also known as itch disease. Very good, Arush, very good. Now here the important thing is that the distribution of the lesion or the site of the itching is different in different age group, and therefore whenever you will have a case history of atopic dermatitis, the question will start with the age, number 1, and it will specifically mentions the site of itching, right? Apart from history of asthma, because in infants we can have itching over the scalp area, then in adults it is cubital or popliteal fossa, right? So in children it can involve the body folds, especially axilla, groin, or popliteal fossa, right? So this is very important for atopic dermatitis. And if I show you in the image, you can look here, face is so much involved in cases of atopic dermatitis in infants, right? And now as the child will grow up, you won't find any involvement of scalp or face. So if there is a case history of atopic dermatitis in an infant, it will specifically mention the scalp or face, right? So that is for infants. Then as the patient grows up, in children it can be anywhere, like it can be in the cubital fossa, popliteal fossa, then anywhere in the crease area, it can be axilla, groin, neck. Okay, so this is for children. And in adults, it is limited mainly to the cubital fossa and the popliteal fossa, right? So you can see the area of distribution of the lesions vary as per the age of presentation, right? So therefore, I'm telling you, in a case of if there is a case history of atopic dermatitis, if the age is given, then obviously they would give you the sites as well. So based on that, you can clearly mark it out as a case of atopic dermatitis, right? So this is very important. In terms of age, you will have specific areas where there will be itching. Now apart from this, there might be some other features, like you might see a Denny Morgan fold. There is an additional fold of skin beneath the lower eyelid. Then the diagnosis is always clinical, right? So for atopic dermatitis, the diagnosis is always clinical. You don't have any clinical test or other measures to reach up to the diagnosis. You have to assess the symptoms, and then you have to reach up to a clinical diagnosis. And of course, for this making a clinical diagnosis, we do use Hannifin and Raska criteria, right? So we use these criteria to reach up to a clinical diagnosis of atopic dermatitis. And yes, most importantly, there would be a history of asthma, either in the child or in the family. So there would be a history of some atopic disorder, in short, right? So this is classical atopic dermatitis. Now I have kept one more question, and let me see if you have got the concept or not. There is a family history of asthma. Now the lady has started with itching in cubital fossa and popliteal fossa. So I think all of you are now must be in a position to make a clinical diagnosis the moment you have all these set of words, right? So what will be your clinical diagnosis here? Lady, family history of asthma, itching in cubital or popliteal fossa. I think everyone can make a straightforward diagnosis just looking at these set of words. Yes, anyone? I think it's not that tough. Yes, please try. What can be the diagnosis if you have these kind of words? And I have just removed the options because I just want to make sure that all of you should be able to make a clinical diagnosis just studying the MCQ statement only, right? And for some tougher MCQs, I have kept the options, but for some simpler ones, and in whom I personally want you to straight away make a diagnosis just reading at the question statement. So this is nothing except atopic dermatitis. So this is what we have already discussed. Yes, Shanwaz, absolutely right. So this is atopic dermatitis. The history of asthma, itching, atopic dermatitis, straight away. Right? So this is how the patient usually presents to us, and there is so much of itching, right? And therefore we call this condition as itch disease, right? So this is itch disease because there is so much of itching, especially in the cubital fossa or the popliteal fossa. So then there is one question, and I think this is one rare kind of questions, and I think it will never be repeated again. So that is Cutis marmorata. Again, Cutis word is for skin. So Cutis marmorata, Sanghamitra. Yes, Sanghamitra, you are absolutely right. Wonderful, wonderful. You are absolutely right. So this is dilatations of the vessels of the skin on exposure to cold, and that is known as Cutis marmorata. And if we just have a look at this condition, you can see there is mottling appearance, right? So you can see there is mottling. Okay. So this is Cutis marmorata, and this is because of the vasodilatation whenever the body, especially of the young ones, is exposed to cold, right? So this is Cutis marmorata, right? And yes, we need not worry, just warm the child and the condition will resolve, right? So this is a benign condition, not to worry about it. So this is Cutis marmorata, and it is not an important question as such, but I just kept it, like I thought it like some unique presentation. So the next question is again like a very easy question, and therefore I haven't kept the options. Let me see if you can answer that or not. So there are multiple warty lesions on the hand. Now, which virus is responsible for this condition? So you can see here, you can see, so which virus you can associate with this condition, which is shown in the image. Now, anyone tell me what condition actually is this? Then only it will be very easy for you to associate the virus with this skin condition. What condition is this? So this is Verruca vulgaris. Yes, Sanghamitra, very good. This is Verruca vulgaris, also known as common warts, right? And if you look at the skin, if you look at the statement proper, they have already mentioned warty lesions. Yes, wonderful, wonderful, Sanghamitra. This is human papilloma virus, okay? So this is caused by human papilloma virus. Now, okay, so you can look here, this is, okay, so these are all Verruca vulgaris and caused by human papilloma virus, right? So known as common warts. Shanwas, yes, this is human papilloma virus, okay? So Verruca vulgaris or common warts. Fine. Chalo. Next question. Now this is again, I think a very rare kind of question, and I don't feel it will be repeated ever again. So the case history goes like, there is a 35 years old male and who is having a hyperpigmented lesion, and there is excessive hair on this lesion, and this is present since last 15 years, and sometimes there might be itching on this lesion, right? So if you look here, there is hyperpigmentation. Yes, you can see the darkness, right? So there is hyperpigmentation, and there are hairs on this lesion, right? So there is hyperpigmentation patch, and then there is excessive hairs. So this is actually known as Becker's nevus, right? So this is Becker's nevus, and it is just, you know, a variety of acquired nevus, right? So this is Becker's. Very good, KK, very good. This is Becker's nevus, and I don't think that it will be repeated again, so it's not that important question as such. So this is Becker's nevus. Now the next question was about the skin, and you have to identify the wrong statement here, right? So again, I think it's slightly difficult question. So now the important thing which you should remember is that there are two type of collagens, collagen type 1 and collagen type 3, right? And the ratio is not 3:2. It may be like the type 1 is around 80% and the type 3 is about only 20%, right? So the ratio is about 4:1. Okay, so the ratio is about 4:1, roughly you can say. So it is not 3:2, it is 4:1, and it means that type 1 collagen is in abundance in the epidermis, in the dermis, right? So this is I think it's not that important question, but I just kept it like that. Chalo. No, this is a very good question, and let me see how many of you can answer this. Elderly male is having severe pain in the chest, just over the nipple, on one side. Now this is very important, on one side. And since last 4 days, patient has developed vesicles also. So now let me give you the keywords. Severe pain. Number 2, unilateral, right? So this is because it is on the one side, so it is unilateral. Then third is vesicles. Very good, Shanwaz, very good, Arush, very good, KK. Yes, wonderful, wonderful. So this is a classical description of herpes zoster, which is also known as shingles, right? So it is on the one side. And see, while we were discussing herpes genitalis, we discussed that there are multiple grouped vesicles, and they are resting on an erythematous base. So something like this is erythematous base, right? So this is erythema or redness, and these are the grouped vesicles. So this is very characteristic for herpes. Similarly, you will see here that you can see the redness, right? I think all of you can appreciate the redness. So this redness is all erythema. So the redness, whatever you are noticing here, is all erythema. And over this erythema, you can see very small vesicles. Okay. So vesicles are actually fluid-filled skin lesions less than 1 centimeter in diameter. So you can see grouped vesicles. So these are grouped vesicles, and this is only on one side, right? So it is only on the one side, and this usually lies along a dermatome. Clear? So this is a classical presentation of herpes zoster or shingles. And of course, please remember the word unilateral. This is very important for shingles. And then pain, extremely painful, grouped vesicles over erythematous base, and importantly along a particular dermatome, right? And this is again, I think most of you must be knowing that it is a reactivation lesion. Fine. So okay, now next question, and let me see whether you can answer it or not. So number 1 is infant, then itching, right? And the mother is asthmatic. And of course, the important thing which you can see here is involvement of face. So involvement of face. So the moment you have 1, 2, 3 and 4, you have these important 4 keywords, I think you can make a straightforward diagnosis of. Yes, so I'm waiting for your diagnosis. Anyone? Infant, involvement of face, severe itching, mother is asthmatic. Now what will be your diagnosis? I think this diagnosis is straightforward. Very good, Arush, very good. So this is nothing except atopic dermatitis. So this is what I want you to remember. Whenever you have these set of words, straightforward jump onto atopic dermatitis, right? Chalo. Now let us see this question, and this is an actually all except questions. So I was bound to give the options to you. Now here the question is like, an adult patient has a skin lesion in the axilla. It is shown here. Now what statement is not true? So you can see there is a hyperpigmentation. This is hyperpigmentation in axilla, right? Now which of the following statement is not true? Very good, KK, very good. Yes, the diagnosis is Acanthosis nigricans. Very good. So the diagnosis is Acanthosis nigricans. And yes, Arush, you are absolutely right. It is not a sign of skin malignancy, right? In fact, it is a sign of some internal malignancies which are not related to skin. And what are those internal malignancies? Any idea? What are those internal malignancies? Yes, Sangamitra, you are absolutely right. But I am just talking about some internal malignancies which might be related with Acanthosis nigricans. What are those internal? Very good. Yes, so one is gastric adenocarcinoma. Yes, and there is one more. There may be lung carcinoma, right? So, but it is not always like that. Sometimes it might be associated, but yes, in majority of the cases it is associated with diabetes mellitus type 2, right? And of course, plus obesity, there might be hypertension, and this all is known as metabolic syndrome. Clear? Yes, so Sangamitra, you are absolutely right. This is metabolic syndrome, which is actually, it's not a condition, single condition as such. It includes obesity, diabetes, hypertension and all. So that is metabolic syndrome. And Shanawaz, yes, in ladies it can be seen in polycystic ovarian syndrome, where we see the characteristic hair and syndrome, right? So in polycystic ovarian disease, you must have heard of hair and syndrome, and this N is Acanthosis nigricans, IR is insulin resistance, and HA is hyperandrogenism, right? So that is hair and syndrome of PCOD. Anyway, coming back to the question, yes, hirsutism is presentation. So it is seen in obese people with diabetes, and you can see the hyperpigmentation here. So BCD are obviously the right options, and A can be ruled out because it is not an indicator of skin malignancy, although it is an indicator of some internal malignancy which can be of stomach or lungs, right? So this is Acanthosis nigricans. Now what condition is this? Any idea? What condition is this? Arush, Sangmitra, yes, both of you are you perfect. This is contact leukoderma, and you see this is the area of placement of bindi, right? So that chemical, it can lead to Shanavas. Yes, this is contact leukoderma, and this is sometimes also known as bindi depigmentation, right? So this is also known as bindi depigmentation, because that is actually the point of placement of that bindi and that glue or the substance. Yes, so this is contact leukoderma, right? So the typical position of this contact leukoderma here, right? So contact leukoderma. Chalo. Next question. Now here it is again a twisted question, and you have to firstly reach up to the diagnosis, then you have to think of the other part of the question. So here a young male is presenting with a hair loss as shown in the image. Now what kind of nail changes will you expect in such a case? So if you look here in the picture, you can see there is only a small area where there is total hair loss. So such type of hair loss which occurs only in a limited area, so that is known as alopecia. Yes, so this is alopecia. Which type of alopecia? Areata. Very good, Sangamitra. So this is alopecia areata, and in alopecia areata we will see pitting of nails. Now please remember, this pitting of nails is not a specific finding. It can be seen in psoriasis as well. So if you see a case of pitting of nails, don't say it is only alopecia areata. It can be seen in psoriasis as well, right? And yes, in alopecia areata, what kind of stump do you see? So there is exclamation mark here, right? So what you'll see here, that is exclamation mark here, because if you see the normal hair, and this is say alopecia areata, so in normal hair you will have something like this, so broad and tapering, right? But what happens in alopecia areata? It is something like this, so broad at the top, tapering at the bottom, and then hair follicle, right? So this is known as the classical exclamation mark here, right? So this is the exclamation mark here, right? It looks like the exclamation mark of grammar. So this is the alopecia areata, right? So here you can see the pitting of nails, right? So here you can see the pitting of nails. Okay, so this is all pitting of nails which may be seen in alopecia areata. Okay, so this is pitting of nails, right? Chalo, next question. Now a female patient, there is fever, photophobia, and then there is photosensitive rash over the cheeks, and this is sparing nasolabial folds. So I think it is a classical case. I think all of you can clearly. Now this is the nasolabial fold, right? If you can see here, this is the nasolabial fold. So this is the nasolabial fold, right? Yes, SLE, yes, KK, Sangmitra, Arush, Sanwas, everyone is right. This is the typical butterfly rash, right? So this is the typical butterfly rash, or what you call the malar rash of SLE, right? So this is the typical butterfly rash. Okay, so classical butterfly or malar rash of SLE, right? And there is sparing of nasolabial folds. Naso means nose, labials means cheek. So those things are not. This is photo is light, phobia is fear or sensitivity here, right? Chalo. So this is the classical. You can see there is no involvement of the nasolabial folds, and you see the classical butterfly rash. Okay, something like this. Clear? So this is SLE. Yes, good. Now let us take another question. Here a 4-month-old infant has been brought, and we can see erythematous rash in the intertriginous folds of the neck. So if you look at the image, you can see the erythema, of course. So this is erythema, that is redness, right? So this is all erythema here, this is all erythema, and in the center, and again you can see these are the body folds of the neck, right? And in the center we have actually some maceration, right? So there can be maceration, and there is, you know, wetness in this fold, and that promotes the growth of fungus. Very good, Sangamitra. So this is candidial intertrigo, right? So this is candidial intertrigo. So this promotes the growth of fungus. So this is a fungal infection, candidial intertrigo, right? So what you need to remember about candidial intertrigo, there is erythema, we have already discussed, there is redness, and there is maceration, just because of there is some, you know, sweat and all, which leads to that maceration, right? So this is a classical itching, always a component of fungal infections. So this is candidial intertrigo, right? So very important. And the classical location include any body folds, and here in the given case it was neck creases. So this is candidial intertrigo. Okay, chalo. Now next question, again a very straightforward question. A patient is presenting with itching of interdigital cleft, right? So interdigital, this area between the fingers, right? So this area the patient is having so much of itching, you can see. So this is a classical case, right? So in between the folds or the web spaces of the fingers, and there is severe itching. Dr. Abhishek, yes, you are absolutely right. This is a classical presentation of scabies, and in adults it is always below neck, number one, right? And yes, affects body folds, right? So affects body folds. It can be the web spaces or groin, right? And classically the itching is more at night, right? So itching is more at night, and most importantly there might be simultaneous involvement of family members. This is very important, right? So it might be the, yes, KK, Sangmitra, yes, everyone is Arush, everyone is right. This is scabies. And one important clue at times you can have that there may be involvement of family members as well, right? And I think most of you must be knowing what are the characteristic skin lesion here. I think most of you must be knowing that it is burrow in the stratum corneum, right? And treatment wise, what you need to do? Topical scabicide, and that is 5% permethrin or BHC, right? And it has to be applied below the neck. Okay, so this is in short about scabies, right? Chalo. And the moment you have any case, yes, Shanawaz, 5% permethrin, any case who is complaining of itching, especially more at night and involving the body folds, don't hesitate to choose scabies as your answer. Chalo. Next question. So here you can see in adults it involves area between the fingers more importantly. Now next question. A patient presented with hypopigmented patch and there is absent sensations. What you need to do to treat such a case? Hypo means less, pigmented patch. Patch means skin lesion more than 1 centimeter in size, non-elevated. Okay. Very good, Sangmitra. Very good, KK. Shanwaz. Yes, everyone is right. So this is a classical case of tuberculoid leprosy, right? So this is what? Tuberculoid leprosy. And yes, for leprosy we need to give multi-drug therapy. So this is the multi-drug therapy. And what drugs we use actually? Dapsone, right? Rifampicin and clofazimine. Clear? So this is a tuberculoid leprosy. You can see a large hypopigmented patch. Okay, means if you look at the color of this area, it will be lighter. This is normal. This is lighter, right? So this is hypopigmented, and if you touch it, there will be no sensation. So that is tuberculoid leprosy, and start MDD, right? So this is tuberculoid, and the important thing about tuberculoid is that insensitive to pain. So no sensations, right? So this is no sensations. No sensations. This is very important. You can see here there is a hypopigmented patch. You can see here there is one more hypopigmented patch. Okay, so this is tuberculoid leprosy. Fine. So very easy to identify. Yes, Shanawaz, Dapsone, Allah nerve involvement. Okay, chalo. What is the clinical diagnosis? If you look at the image, what diagnosis you can think of? And again you can see very good, very good. So this is grouped vesicles number 1, right? And then there is an erythematous base. So this grouped vesicle is characteristic of herpes, right? And since it is affecting the lips, so it is known as herpes labialis. So this is a case of herpes labialis. Yes, KK, Sangmitra, Arush, Shanwaz. Yes, everyone is right. So this is herpes labialis. So erythematous base, grouped vesicles, think of herpes infection. So since it is involving the lips, so this is herpes labialis, right? Now look at the image and let me see if you can get up to the answer or not. So tinea cruris, tinea corporis, granuloma, psoriasis. What is this? Any idea? Now if I draw you the lesions, it is something like this. Okay. There is central clearing, number one, right? There is annular lesion, and sometimes we can have scales here. Yes, this is tinea corporis, right? So then is tinea corporis. Tinea is actually fungal infection, and corporis means trunk. Okay, so this is tinea corporis, and you can classically see annular lesion, something like this. There is central clearance and there is a rim at the periphery. Yes, so Shanvas, KK, Sangmitra, this is tinea corporis, and this is a classical presentation of tinea cruris. You can see the central clearing. In the center there will be no disease as such. It will just appear like the normal skin, and then it's a circular lesion kind of thing, and therefore we use the word annular. So you can see a ring kind of lesion here, right? And here the edges are raised, and sometimes we can also see scales, right? So this is, and sharply marginated. You can clear cut define the limit of the lesion. So this is typical tinea corporis, right? Very easy to identify, tinea corporis. Now what condition is this? Again, it is slightly difficult from student part, but I just kept it like if we can discuss the concept as such. Now number one here, this lesion is seen on sun exposed part. Number one, it is present on the sun exposed part. Okay. Number two, what you can see here, there is hyperpigmentation, okay, and there is a rim of hypopigmentation, right? So again, if I show you the numbers, like of course this is 1 and 2, of course. So on the over the face, sun exposed part, 2, it is hyperpigmented. You can see the dark areas, and if you look properly here, you can see a white margin. So you can see a white margin here. So the lesions, they are surrounded by some white area. Okay, so you can see the white area surrounding the lesions. So white area surrounding the dark lesion. So these are known as the hypopigmented rims, right? So these are 3 important features which helps you in making a diagnosis of actinic lichen planus. Okay, so actinic lichen planus. And for Acanthosis vulgaris, I have a different question. We will come to that. It can be seen anywhere, Acanthosis vulgaris, and this entity is only on sun exposed part. So this is actinic lichen planus. Yes, Dr. Abhishek, you are right, and we will have another question for Acanthosis, don't worry. Anyway, so this is actinic lichen planus, sun exposed part, hyperpigmentation surrounded by hypopigmentation. Okay, so if I, yes, this is a better image here. If you can see, number one, face, what you call sun exposed part, right? Then number two, you can clearly see the pigmentation, hyperpigmentation. So you can see the hyperpigmentation very clearly, right? So this dark is all hyperpigmented area, right? So 2 is hyperpigmentation, and just see on the margins of this hyperpigmented area you can see a white rim, right? Clearly you can see a white rim. So this is all hypopigmented rim, right? So there is hypopigmented rim. Clear? So 3 classical features, and you can say that the given case is actinic lichen planus, right? So this is actinic lichen planus. Now a case was having recurrent oral ulcers and genital ulcers, and there is uveitis as well, which is associated with fever. Now what will be your diagnosis? So the important clue here is ulcers. It can be mouth or what you call aphthous ulcers, and it is over the genitals also. So the moment you have this kind of presentation, yes, Shanavaz, very good. The condition is Behçet's disease, right? So there can be uveitis as well, but this ulcer is a classical description for Behçet's disease, right? So classical genital ulcers or oral ulcers. The moment you have these 2 words, don't hesitate to go for Behçet's disease, right? And it might be supplemented by keywords like uveitis or bloody diarrhea, right? So this is Behçet's disease. Now identify this condition, and here you can see crocodile like skin. What is this? This is a disorder of the stratum corneum actually, and quite easy to diagnose. The moment you see the image, you can straightforward label the case as a case of, yes. So what is this? Any idea? Very good, KK, very good. So this is the classical picture of Acanthosis vulgaris. Yes, Sangmitra, this is Acanthosis vulgaris. Okay, so classical, and you can identify it so nicely. And again, it is a genetic condition, right? So this is all Acanthosis. Shanavaz, absolutely right.